Welcome to the Urgent Care Association's Solutions on Demand webinar brought to you by HealthTrack RX. Today we will discuss the role of rapid multiplex PCR to optimize clinical decision-making when evaluating infectious disease complaints in the outpatient setting, and really focused on the heat of the summer. Change the diagnostic challenges that you'll see in your clinic during these summertime months. And to work through these cases, we're joined by two experts in molecular infectious disease diagnostics and urgent care medicine. I'm your moderator, Ben Favre. Dr. Janie French, who is a microbiologist and medical science liaison for HealthTracks. Dr. Stephen Goldberg, who is an urgent care practitioner at University of Louisville, is also the chief medical officer for HealthTrack RX. And with that, let's jump into our first case. So Dr. Goldberg, we start off with a case, a 70-year-old patient into your clinic, wants to just get checked out, denies any subjective complaints. He says he has a new relationship, and he also has a long-standing primary care physician. No relevant medical history other than that. Dr. Goldberg, what are your thoughts when someone comes in and has a case like this?
Well, Ben, a lot that informs our approach is what's said and what's not said. So what's first interesting is that this person has an established primary care relationship and is choosing not to go that route for this problem. That's noteworthy. Also, we're all reading that sexually transmitted disease events in those above 65 are becoming more frequent. This person's in a new relationship and very well might be experiencing symptoms they've never had before. They could be confusing, they could be embarrassing. So those features could make the evaluation a bit more difficult.
Janie, what jumps out at you about this presentation?
Yeah, so I think there's a few things. As Dr. Goldberg said, STIs pose an important public health challenge. Early diagnosis and treatment is critical to prevent their onward transmission. However, it's also important to understand risk in a case like this, especially if they're simply requesting to get checked out without any subjective complaints. Because we all want to be good antibiotic stewards and avoid unnecessary antibiotics if it's not actually indicated.
Very interesting. Thank you. So Dr. Goldberg, on clinical exam, no positive findings, and in the laboratory, no point of care test available. So what's your next step here?
Well, Ben, first I'll note it's great to have a microbiologist help us think through these cases. It really helps broaden your understanding of the environment and considerations as you're evaluating an individual patient. So that's great for today. What I would say is the findings of nothing on exam aren't remarkable and is quite common. And in the urgent care center, usually the only point of care testing that might be relevant to this problem could be a urine dipstick. And it likely wouldn't offer some insights for this particular person's complaint. So securing a collection for a multiplex PCR evaluation that could come the next day could give some precise information that could inform our diagnosis and treatment. And then the practitioner needs to make a decision based on the history, exam. Do you use empiric treatment or do you wait for more specific diagnostic insights?
You mentioned we have a microbiologist here. With that, Janie, walk us through from a microbiology perspective, what's the pathogens we need to be concerned about, and how are you thinking about this from a microbiology perspective?
If the patient has no subjective complaints and the exam is unremarkable, providing antibiotics immediately in the clinic might not be necessary and could drive potential overtreatment. However, there are some other microbiologic factors that we may want to consider. As Dr. Goldberg mentioned, STI complaints in patients over 65 have risen over the past decade. For example, in the United States, rates of gonorrhea have gone from 1.5 to 5.9 cases per 100,000. So almost quadrupling in the past decade. We also know that there are increased rates of STI visits in the summer months, as shown in this figure from the Journal of Urgent Care Medicine. We know that this patient may be at risk for an STI, but there's a few additional things to consider based on their sexual history and what information you can glean from them. Maybe you want to consider also looking at HIV or syphilis testing. So then what actual diagnostic techniques are available to you? Well, culture is not commonly used for sexually transmitted infections because they're difficult to grow in culture, and PCR is typically considered the standard of care. Beyond that, they may consider RPR if they're interested in testing for syphilis as well. I want to take a second here to talk more about PCR because this will be important throughout the talk. What is rapid clinically actionable PCR?
So Janie, to get into that, post-COVID, everybody knows what PCR is, but how is rapid clinically actionable PCR different than what people know as just regular PCR testing?
So there's a few different flavors of PCR, both in, is it testing for a single target? Are you testing for a very large panel of targets? How is it reading out? Is it just a qualitative result that it's detected or not detected? Or is it quantitative? Is there some sort of microbial load interpretation there? We need to talk more specifically about rapid clinically actionable PCR, which is based on this IDSA public policy paper called Better Test, Better Care, Improved Diagnostics for Infectious Diseases. In this, they outlined 5 criteria to improve ID diagnostics. So they recommended that diagnostics, first of all, be easy to use. They then need to identify a specific pathogen and then provide rapid results to impact clinical care. Because if results take many days or even weeks to result, often at that point, the results may no longer be relevant to that patient scenario. But beyond that, they should also provide some sort of resistance information about antimicrobial agents. And then they need to be effectively communicated to the clinician so that the information is clear and can be acted on immediately.
Thank you, Janie. Back to the case. Dr. Goldberg, you now have a little more information. You have a good perspective from a microbiologist. Walk us through your clinical decision making to get to a diagnosis and a treatment plan.
Will do, Ben. And as we'll do for our audience today, we won't give the answer about the case, but we'll look forward to their input and discuss that. So based on this information, we have someone that has a new subjective complaint, an unremarkable exam, not clear that they have a past history, and we don't have any information about the local environment, the prevalence, for example, of sexually transmitted disease. So the practitioner has to make a decision. Do I empirically treat or not? And if not, waiting for definitive diagnostics. And then also what to include in your evaluation. Do you need to think about, for example, HIV or syphilis? So those are some of the questions that we think about when evaluating someone with this profile and this problem.
Very good. So with that, we have our first audience survey question. In this scenario, do you prefer empiric treatment or diagnostic test results driven treatment in your setting? And you can click your answer there, and we have 20% voted so far. They keep on coming in. So about half the people have voted so far. I think that's a big enough sample size. 93% are saying results driven treatment. Janie, Dr. Goldberg, what are your thoughts? Stephen, why don't you lead us off?
And again, I think it depends on the patient profile. I think based on this patient's profile, I would have opted for results-driven treatment.
Janie, what would be the case for empiric treatment? In what scenarios would empiric treatment make sense to you?
I think as a microbiologist, the best approach is informed by a few things. The patient's past history, how much information are they willing to share with you? Can you get a good idea of the risk factors? But then also the prevalence of sexually transmitted infections in the practice or in the community. And if the risk for an STI based on these 2 factors seems low and there are no symptoms, waiting for test results may prevent unnecessary antibiotic exposure. But if during the course of the patient history, you find out that they may be at elevated risk and that there's a high prevalence in the community, empiric treatment right then and there makes sense, especially if you're concerned about losing the patient to follow up.
Yeah, that loss to follow really kind of makes this complex in that scenario. Well, thank you all both for your insights today. Dr. Goldberg, any final thoughts that you want to share with our audience before we get to questions?
Well, 3 comments, Ben. It's always fun to have a microbiologist with you to offer the larger context when evaluating patients, but we don't have that opportunity regularly, right? So we've got humility about that. The second is infectious disease are a common problem in the urgent care setting. I see it regularly. I saw it yesterday in the clinic. And then finally, you really want to get it right, and getting it right involves knowing what types of infections you're more likely to see in the summer versus other time during the year.
Eliminating that clinical confusion and getting the patient comfortable with what you're doing seems like it's really important. Jenny, what about from a microbiologist perspective? Anything to close on?
People are generally really familiar with the seasonality of respiratory infections occurring at higher rates in the fall and winter. But there are also considerations for summertime infections because environmental changes like increased UV exposure causing higher rates of shingles episodes or increased temperature and humidity increasing fungal infection rates are common. And there can also be behavioral changes. People are going to go to community pools where there may be exposure to waterborne illnesses, or there may be increased exposure to environmental toxins like poison ivy. Thinking about the risk factors of different infections and the prevalence in the community will be helpful in diagnosing some of these summertime infections.
With that, we will end. Thank you for joining us for this Urgent Care Rounds brought to you by the Urgent Care Association Solutions webinar and Health Track RX.